Everybody. I'm Sarwar. I think I've spoken to a few of you guys on the WhatsApp groups and various contact that you've come across me in the past. I'll be doing a talk today on why I think that occupational medicine should be a career choice that we should all be considering, and something that hopefully, even as a portfolio career or as a full-on career, hopefully this presentation will give you some idea of where we're going with it and what kind of things it involves. A little bit of background about me. So I entered occupational medicine in September 2019. I work for Medigold now, and I'll just be going through a bit more detail about how I got to this place thereafter. Topics I'll be covering today. What occupational medicine involves, why we should be choosing it, the different routes that you can become an occupational health physician, and the different levels of specialism that you can achieve. I'll talk a little bit about my career route and how I got to where I am today and where I want to be heading myself. But also, I'll be talking about the other opportunities and other different routes that other people can consider as well. A day in the life of an occupational health physician. So what I do on a day to day, and just give a little picture of how I do my role. I'm also going to talk about COVID-19. It's very relevant at the moment, and occupational health has been heavily involved in that, and just give an idea of how it all connects together. I'll talk a bit about the Society of Occupational Medicine and its role with occupational medicine in general, and how to become a member and what the benefits are for that. And then I've got a question and answer session at the end. If we have time, I have had some fun quiz questions that I put together that we could go through about different kind of dilemmas an occupational physician would go through. But we'll see how we get on because we only have an hour, I'm afraid. So, how did I get here? Well, I did medical school and graduated from Barts in London in 2012. Like most of us, we have to do a foundation year, so I did FY1 and FY2. After kind of FY1, we were like given that opinion, that opportunity to apply for our posts after F2, and I think often a lot of us don't really know where we were going to go with that. I think a lot of us, and I think it's more common now that people do years out afterwards, and that's something that I did after F2 because I didn't really know what I wanted to do. I kept getting pulled into different directions during each of my rotations during foundation year. I think I also decided I didn't really want to subspecialize to the level that I'll be doing exactly the same thing every day or dealing with such a particular niche as such. I wanted to be a bit more general, like GP or general medicine or general surgery, for example. So I did locum years. So I did FY3 and FY4. So a couple of locum years during that time, I think, and a lot of people would have undertaken this or done a similar thing. I saved a lot of money. I did a lot of traveling. I worked in a variety of rotations to try and get a bit more of experience and perspective in terms of the different areas of medicine. And in that time, I was able to buy a house and get married and do all the other things that I wanted to do. So it was quite a useful time. After FY4, I felt that it was time for me to start choosing what I wanted to do. And at the time, I was kind of pulled towards GP. I did my GP entry exams and got a rotation in East of England Deanery. But I still had a few months to go, and that's when I decided that I would go into disability assessments. And I'm sure a lot of people have seen those adverts that are out there. It's not quite occupational medicine, but the good thing about the disability assessments is that gives you that experience in terms of the private setting. Also gives you experience of not being in a treating role, dealing with kind of legislation, report writing, and just a kind of different way of thinking of medicine and talking more about the functional aspects and how it affects you on a day-to-day basis. So I did that for a couple of years, and then I was thinking to myself, what next? Well, that's when I came across occupational medicine. My experience of occupational medicine was at that time, immune status, PEP, and just in general, it was something that we had when we would start a new rotation, but nothing else. But once I looked into a bit more, I realised that actually this is a whole speciality within itself, and I needed to look at how to get into that specialty. And that's when I came across the Diploma of Occupational Medicine, a qualification that can be done after full registration with the GMC, so after FY2. And I did that off my own back. I underwent the self-directed learning of the Manchester University course, the compulsory course over 6 months. So I did that in 2018. So I did that in my own private time. It was quite useful, especially because I don't really deal well with lectures. I've never been one for lectures. I like to read and learn about things myself. And I completed that and then completed the Diploma of Occupational Medicine in November 2018. After that, I set up a LinkedIn. I changed my CV, so it was not the kind of NHS one, which is about 7-8 pages or so, asking about audits and things. It's more of a 2-page document that talks more about transferable skills and things. And I started seeing jobs advertised for occupational health physician roles. At the time, I contacted the Society of Occupational Medicine. Were very useful. It gave me a few pointers of where to be looking and what I needed to be doing. And a few months later, in March 2019, I got an interview with Medigold and then started working in Medigold in September 2019. So, what is occupational medicine? So, in simple terms, occupational medicine is looking at the effect of health on work and work on health. Okay, and that's very simple. It essentially combines law with medicine. There's a lot of legislation that I've listed, and there's many more that it comes across. And the idea really is that you're the bridge between the employer and employee, as well as the treating physicians such as a GP and specialist. And you would be doing assessments and advising regarding fitness to work and whether a person's fit to work. Do they need any adjustments? Do they need any restrictions to their role? And the kind of impact that the health and work would have on each other. It's a non-treating specialty overall. Our job is to advise mainly. We do deal with a variety of hazards and risks, with physical, chemical, biological, psychological. We'd advise about rehabilitation, how to get people back into work with certain health conditions, and the legal implications of for the employee and the employer. So here I've listed just a few things that occupational health deals with. Health prevention and health promotion is a bit of a crossover with public health, but that's something that occupational health also deals with. We'd focus more on work when we talk about that, but of course this all connects together. With risk assessments, we look at the hazards, we look at the risks in the workplace. We can advise on risk assessments, whether we think that the employer is doing their statutory duty and of doing risk assessments, reducing the risks as far as reasonably possible, and what kind of control measures a risk assessment should be suggesting in terms of protecting worker health. Health surveillance is dealing with how the health is impacting work and work is impacting health, as I said before. So more for longer term conditions, but also with specific hazards such as ionizing radiation or lead or asbestos, and how it affects a worker if they're exposed to it. We deal with giving impartial and independent advice, as mentioned before, and we give this into a report. The idea is to make it into non-medical jargon so that the employee and employer can understand. And this is essentially an extension of the fit note that a lot of GPs would be given, the Med 3, as a lot of you may have come across. We give it a bit more detail. We take into consideration the role, the aspects and requirements of the role, the physical and mental health problems, as well as the functional elements, any physical or mental function problems from the symptoms of a health condition, for example. And then we would also look to address work issues, and I'll show a little bit more about that with an example report that I've put together. Occupational health also deals with medicals for work. So I deal with DVLA, I deal with rail, train drivers. There's also aviation medicine, so pilot medicals, diver medicals, There's also drug and alcohol testing, and pre-placement medicines of medical. So for those people that have health problems and have applied for a role, are they fit to do that role? Do they need any adjustments or restrictions to help them in that role? Management referrals is the mainstay of what an a medic does. We deal with the complex cases, the ones where the employer's not really sure what to do and want to know more about how the health affects their work and vice versa. And this deals with sickness, absence, fitness to work. We advise on the Equality Act and whether they would have a disability or not, according with the legislation. We also deal with reasonable adjustments, so what the employer should really be considering to be putting in place in order to fulfill their duty of care to their worker. And often work-related stress and the medical aspect of stress is something that we look into. Ill health retirement and pensions is something we also do. So for those workers that have a health problem longer term, can they retire early on health grounds? We look at the criteria for pensions and ill health retirement, and we advise based on that criteria and that legislation, do they fit the bill, and would they be eligible, and what level of pension should they be getting? Often, as you can imagine, with ill health retirement and pensions, we're dealing with large sums of money, 5-6 figures, maybe more, depending on what the job role is. So these are really big, important decisions and advice that we give for that. And this can obviously affect insurance from employers and employees as well. And I wrote a little bit about the subspecialties. Those are a few subspecialties that we can look at. There are many more. So other things I've missed out there, things like military, cruise ship, boats, and specific hazards, so like ionizing radiation, asbestos, and lots of different areas that people can look into if that interests them or if that's something that they're involved in on a day-to-day. So, well, let's look a little bit talk a little bit into about the roots of occupational medicine. So, how is occupational medicine structured as a whole? Well, occupational medicine is a specialty as part of the Royal College of Physicians, so it's a medical specialty. It has its own faculty called the Faculty of Occupational Medicine, FOM otherwise known, and it's they are the kind of the body that deals with the training and the accreditation of a occupational health service or a doctor. So essentially deals with all the exams, deals with all of the statuses of being a consultant or a specialist or not. There are two main routes to get into occupational medicine. There's the training route, which is the very kind of obvious one that a lot of people would have come across, ST3 to ST6. Essentially, you apply, you get into a training route, a training role, get given a number, and then you essentially either work in the NHS, you can also work in military, and there are occupational health companies that now have training routes as part of them. So they essentially take NHS doctors into their company and they would oversee their training from ST3 to ST6. And you would still do those kind of ARCPs and go through each year according to the curriculum and the requirements. There's also the non-training route. So the beauty of occupational medicine is that it's very flexible. It can accommodate all variety of backgrounds, whether you're an overseas doctor, whether you are a consultant in another specialty and decided to change your mind, or whether you don't have the traditional background of F1, F2, CT1, CT2. You can look at trying the non-training route and essentially enter the specialty through almost like an alternative route. By doing this, that's the route that I'm taking, and you have a variety of routes to get up to consultant level, and I'll talk a little bit more in detail later in this presentation. But essentially, with occupational medicine, you can either become a generalist, and all you would need for that is a diploma of occupational medicine. And this is often what a lot of GPs do. For example, they've already done a CCT. They don't really feel that they want to progress and do another training program, but they want to add another quiver to their bow, and they want to have more of a subspecialty. And the diploma of occupational medicine allows for that. Or if you're a bit younger, or you want to progress further and you want to aim to become a specialist in occupational medicine, and it's like the main role that you do, then you can look at doing that. And there are two kind of qualifications that allows you to become a specialist. So the AFOM, which is an associateship, and this is something that you can get after the Diploma of Occupational Medicine. Or you can get the MFOM, which is what a consultant occupational physician will have after their name, and that's what you get if you do the training route as well, or if you get through there through CSER, which I'll talk about a bit later. So a little bit about the training route. So as I said, you can do this in three places normally. You can do this in the military, NHS, and industry. You would be required to do the F1 and F2, and it's more traditional. So you'd have the CT1 and CT2, or an ST1, ST2, depending on what subspecialty you do. So a lot of GPs, for example, would do up to ST2 and then think about entering occupational medicine thereafter. They'll probably finish their CCT and then do it. Or if you just did, say, for example, a medical specialty and you did your CT1 and CT2, for example, and you got the MRCP, then you might think, okay, actually, I want to change and I want to go into occupational medicine. The way to kind of find out about the requirements of what you need in order to get through the training route is through the National School of Occupational Health. And I recommend you search them on Google and click on that, and they have specifications that you require. So what you essentially need in order to be able to apply for an interview and then get a scoring system and get a number. As I said before, the training route is ST3 to ST6, so you're reg from ST3 and you go all the way through to ST6, and then you can become a consultant as long as you're passing each year in the ARCPs. During the training route, you need to do two exams, the MFOM Part 1 and the MFOM Part 2. The MFOM Part 1 is the MCQ part of the exam for the Diploma of Occupational Medicine. So it's exactly the same exam, but the Diploma of Occupational Medicine has an extra exam. So a lot of trainees end up doing a Diploma of Occupational Medicine because they may as well get another qualification out of it. You also, and I haven't included it there, but you do also need to do a dissertation in order to become a consultant in the training route. And a lot of trainees do that through their own methods, but others do, for example, an MSc, which would require you to do a dissertation anyway. And as long as the FOM are happy with that and your title and your thesis, you can submit that as part of your evidence. And as I said, after ST6, after you've done all of the ticked off all the curriculum and passed all your ARCPs, you become a consultant and you get the nominals at MFOM and you become an accredited specialist in occupational medicine. So a little bit more about the non-training routes. As I said, it's very flexible. So you don't necessarily have to do what I've done and done a couple of years in between after FY2. You can also have become a registrar in another field, or whether you're an overseas doctor and you don't really follow the traditional route of a UK doctor. There are a variety of ways, but essentially what you need to be is to be get to a level where you're fully registered with the GMC. You then can apply to sit for the Diploma of Occupational Medicine exam. You don't need to be in a training post. You can do this at any time after FY2. And as I said, I did that at the same time as doing my other role as a functional assessor when I did it. The Diploma of Occupational Medicine is the FOM exam, involves two parts of the exam, the MCQ and the Viva and Portfolio. Once you pass those two, you get the nominals DOccMed after your name. And that is essentially the gateway to getting into to occupational medicine using the non-training route. Most occupational health companies, private companies, will be looking to hire you once you have that. After that, and you want to progress, you can sit the part 2 of the MFOM exam, the exit exam for the consultancy, and you then gain the nominals AFOM, which is Associate Specialist in Occupational Medicine. So this is not, you're not on the GMC register, it's something that the FOM have recognized a lot of people end up doing, and a lot of people wanted something further than a Diploma of Occupational Medicine only. So they allow you to use that phrasing of associate specialist, and essentially you have the knowledge of a consultant because you've done the exit exams, but you're obviously not in a formal training program, so you haven't had to do any of the ARCPs, any of the dissertation, etc. And this is something which a lot of people get to, and they're happy with being AFOM. AFOM is a senior occupational health physician, and a lot of the more senior roles you should be able to do with an AFOM. And if you want to go further, then you can do something called the CSER route. So the CSER route is where you essentially prove to the GMC and prove to the FOM that you have done all the things that a trainee would have done from ST3 to ST6. And it's just essentially a giant portfolio, which is like a more enhanced version of the appraisal that we have to do every year, where you have to show and tick parts of the curriculum and show that you are developing and you are becoming more experienced as an occupational health physician. Within CSER, this is where you would have to do a dissertation like the trainees do and prove that you've covered all the curriculum for that. And you need at least 4+ years worth of evidence. Now, the beauty of the CSER route, again, is that it's flexible. Those people that have had breaks in their careers, those people that are part-time, those people that have been working in occupational medicine for many years and suddenly realize that actually they've probably got enough evidence to prove to the GMC and the FOM that they've done enough. That this is where CSER becomes really useful, and it's very helpful for those who have lots of other things going on. And when I say 4+ years, you don't have to do it within 4 years. You can do it for longer than that, but you need to have the equivalent of over 4 years. So essentially what an ST3 and ST6 would have been doing. And then after that, you get it's almost like another alternative route, and you get the NOMIALS MFOM status as a consultant. So you would be an accredited specialist in occupational medicine. You would be put on the register, the specialist register of occupational medicine. So another way to get to the consultant level. So, a little bit more about the day in the life of an occupational health physician. Now, I know a lot of people have contacted me and contacted the SOM for shadowing opportunities to be able to see what we do on a day-to-day. Unfortunately, COVID's been really restricting with that, but hopefully this webinar will give you a bit more of an idea of what I would do. So, I work full-time 5 days a week. A lot of occupational health physicians only work part-time, 1 or 2 days, maybe 3 or 4 days. The main thing is that it has that flexibility, and you can kind of discuss your contract with your employer based on that. I would normally get in about 8:30. This will give me time to answer any emails, any queries from previous reports I've done. It will also give me enough time to prep the cases. A typical day is kind of 9 to 5, by the way. I didn't include that in the slide, but certainly it depends on what kind of how fast you work and what you undertake on a day-to-day basis. I typically would have 4 45-minute appointments in the morning, and then I'd have a 1-hour lunch, and then I have 4 45-minute appointments in the afternoon. Okay. It varies from different kind of companies about the length of time, but generally speaking, it's 45 minutes to an hour for an appointment. This, as you can imagine, is plenty of time for you to be able to introduce yourself, explain the role of occupational medicine and occupational health, be able to take a reasonable history, a clinical and functional history as well. And you can also do a clinical examination depending on what you need to do. And it would also be enough time for you to essentially write the report. So often within the 45 minutes, I'd be doing the whole thing, write the report, send it off, and not really think about that appointment again. But often it will come back later on if there's a query or question which I can answer. So as you can see, it's a lot of time. It's more relaxed, and you're not rushing like some of the hospital clinics you would or even the GP consultation, which I hear can be very pressured within 10-15 minutes to be able to do everything. And as I said before, you're not a treating doctor, so there isn't really any kind of prescribing or any treatment going on. It's more of gathering the evidence, using your opinion, making an opinion on fitness to work, and writing a report for it. In my day, I'm at Medigold. I get an hour admin time from 4 to 5 o'clock that allows me to kind of sweep up any kind of issues. Maybe there's an appointment that overran slightly earlier, or it was a bit complex and I needed the full 45 minutes to talk to the employee. But generally speaking, that gives us enough time to kind of round it up, and it helps me. I work in London. I often wanted to avoid the rush hour, so I would basically get home and then finish my admin later on. Those who have kind of childcare issues or anything like that, it's a perfect time for you to use that time how you want. And if you wanted to finish off your reports and things in your own time later on, then you can do. The main thing to remember with occupational medicine, there is no emergencies. There's nothing that significantly needs requiring attending right now, and that way you get an ample time to be able to complete your reports. And if you're like me, I like to get it done straight away, but other people may have other things going on in their life and they want a bit more flexibility. So I'm sure, as you've worked out, there's no there's no weekends and on calls or night shifts with occupational medicine. There is I've written some home working, but in COVID actually that's a lot more now. I think the majority of occupational health physicians are working from home and doing telephone and video consultations, which is useful. But you can go into the office and you can also visit the site. So you may be asked to go and visit a workplace, and this is what happened to me recently, where I had somebody who had a physical problem in a construction company. And the employers were saying that they wanted me to go and have a look and actually have a look at how they would climb the stairs and get on the scaffolding and do their part of the role. And that is something that an occupational health physician may be asked to do, and it's quite interesting to see the weird and wonderful jobs and how people do that. On the right, I've listed a whole variety of kinds of assessments I have. I mean, I'm not going to go into a lot of detail between each one, but I think the main point I wanted to kind of highlight is that there's this huge amount of variability. Okay, no 2 days are the same, and it isn't just set 45-minute appointments. I'll be doing a lot of stuff in between, and I think the key to a person's happiness in their career is the variability. I think even if the most exciting job you do in the world, if you're doing this kind of every day, the same thing every day for many, many days, weeks, months, years, eventually it's going to get a little bit boring. I think the key to being happy and content is that variability. And I find that occupational medicine allows for that. And there's a wide variety of things that I'll be doing on a day-to-day basis. Something to point out a little bit is regarding the business and tenders advisory policies and stakeholder. This is a very kind of useful thing that I like to get involved in and get involved in the business side. So I would be involved in trying to comment on somebody's policies, so HR policy in a company about health and safety. I'd also be looking at trying to get involved on the business side. So how would an occupational health contract with a business be kind of negotiated and organised, and what kind of services would an occupational health service offer a business, and how would it be useful for that business? So it's quite a useful thing for you to get used to if you're interested in that kind of thing. I didn't include here, but there's also things like tribunal attendance. So rarely you will get a case that unfortunately there's a big dispute between an employee and employer, and it goes to employment tribunal with a judge, and you may be asked to attend based on a report or opinion that you gave. Now, that's not to say that you're going to get in trouble, but what it's saying is that you may be asked to go and attend to give your professional opinion regarding the person's ability to do their role and their capability to do their role, and the adjustments that the employer has put in place, whether you think it's reasonable. So this is something else that you might be interested in, and again, gives more variability to your role. So I included this because I get asked quite a lot about what a typical report would look like. Now, obviously, this is a template and not a real report, but as you can see with the bold headings, you would have certain things that you would put in your report. An occupational background, so how long has the person been doing the role? What is their role? What does it involve? Have they been sick? Have there been any performance issues? You'd go into the medical factors, so you take a clinical history like you would with any medical professional, and you then also take a functional history. So, for example, if somebody had a back pain, can they wash and dress okay? Are they able to bend down and do their socks and shoes? Can they lift the laundry basket? Are they able to hoover? Are they able to cook and carry pots and pans? And you would use that information to try to relate to their work, essentially, and be able to kind of use that as justification for why you think this person is or isn't fit to work. You can also do a clinical examination. So I would also be doing an examination like anybody would. I would listen to somebody's chest. I would take a blood pressure. I would listen to their heart. I would look at certain kind of rashes or problems with their feet, for example. I'd do cognitive testing in MSc as well. And, you would still do that kind of thing, but obviously you get more time and it's in a bit more of a relaxed manner. And obviously the opinion outcome, this is essentially the bread and butter. It's what you get paid for as an occupational health physician. So are they fit to work? If they're not fit to work, why not? And how long are they likely to not be fit for work? Is there any adjustments or restrictions you could suggest to allow them to return to work? And are they temporary or are they permanent? You would then base that on medical evidence, you would relate it to legislation, and you would then, on the next page here with the answering specific questions, the employer would ask specific questions regarding the person's health and their workability, and you would answer those specifically. And those that are eagle-eyed, there's a bit about the Equality Act, which is something that you'd be expected to comment on. The Equality Act is a legal determination, so only a judge and an employment tribunal judge would be making that decision. But often they ask you, doctors, whether you think they fall under it or not, and that essentially will allow the employer to determine whether it's very necessary and what the kind of things they need to do in order to comply with the law. Otherwise, they're likely to get in a lot of trouble. So, what is next for me? So, I think as I've already alluded, there are lots of things you can do. So, if I wanted to, I could just stop where I was right now. I've got the Diploma of Occupational Medicine. I do a wide variety of assessments, and actually, I don't really need to do any more. I'm on a comfortable salary, and I've got what I want really, which is the variability, the ability to do lots of things and keep myself interested and be able to do lots of things. But I think for me, I'm one of those people. I'm fairly young in my career. I still have that kind of want to become a specialist and have a niche in my expertise. So that's why I'm looking to proceed. So I was sponsored to do the Masters of Occupational Medicine. So I'm in my second year at the moment, and that's very useful because it gives you a lot of background knowledge. It essentially gives you an extra qualification, and it gives you a lot of basis for the exam for the next part, which is the MFOM Part 2, which I hope to do later this year. The MFOM Part 2 is obviously the exit exam, and there's a huge breadth of knowledge that you need to know. As you can imagine, all the weird and wonderful chemicals, biological hazards, physical hazards, and all the legislation. And there's a variety of fields that occupational medicine encompasses, from diving to aviation to ionizing radiation, lead, asbestos, noise, vibration. So there's a lot of things that you'll cover, and the masters helps with that, but not absolutely necessary. After the MFOM Part 2, as I said before, you would then get the nomials AFOM and become an associate specialist in occupational medicine. For me, and for a lot of people, they would just stop there. I think for me, I still want to go further, and that's why I've already started the CSER route. So it's essentially a prospective application. So I've just finished like my first year as such, my equivalent of ST3, and I'm just getting that evidence, ticking it against the occupational medicine curriculum, and gathering that evidence. And hopefully, after the 4 or 5 years or so, once I've got everything together, I'll be submitting that to the GMC and the FOM, and hopefully have enough to be able to be classed as an MFOM and a consultant occupational health physician. So, reasons why I think everybody should be doing occupational medicine. So you can see there's quite a lot there. As I said before, the 9 to 5 work is attractive. The no nights and no weekends, it allows you to have a quality of life and essentially be able to work to live rather than live to work, if you know what I mean. And I've included the salary. Obviously, this is something that a lot of people be looking at. It's very competitive, as you can imagine. In the private occupational health sector, there is a lot of scope for salary, and often occupational health positions are comfortably within the 6-figure salary, depending on your experience, of course. Very useful, particularly if you want to do part-time, so you could pretty much live a very comfortable lifestyle even on 3 days a week, I would imagine. Very useful for starting a family, buying a house, or even if you wanted to do other things like travel, for example. I say office-based work. It's not office-based. I mean, my clinic in London is in Liverpool Street, and for those who are aware of what London's like, the Bank Liverpool Street area is where a lot of the banks and a lot of the kind of corporate areas are. But in the clinic, I will still have a couch. I will still have all the equipment. There'll be nurses doing vaccines. There'll be nurses taking blood and doing urine tests. And I'll have all the weird and wonderful instruments to be able to do neurological examination, for example, and have a desk with a computer on. So very similar to kind of GP, but it's in a corporate environment as well. So it's you get a bit of both essentially. But for example, in an occupational health clinic, it wouldn't be normal to have a defibrillator, for example, in the private sector, and there obviously is no crash team or anything like that at all. So it is slightly different. I mentioned before about the length of an appointment, so 45 minutes to an hour, very comfortable, good time to be able to get a history and examination. You could also get a help if you wanted another opinion in that time. You could write the report within that time if you're fast at typing, or what I do is I dictate my reports using voice dictation software, and it just appears on the screen. But plenty of time, and obviously if you're overrunning a little bit, and it gives you that kind of breathing space in between appointments. I mentioned a bit before about the variability of types of assessment and the wide scope of medicine that I see. So as you can imagine, I see a wide variety of mental health, physical health, functional disorders, and a single worker might have several of these, and it's a very interesting thing. I might be dealing with a schizophrenic teacher, and then the next minute I'll be dealing with somebody that's had a stroke and works as a graphic designer, for example. So it's very different in that sense, but very interesting, I find, anyway. And you work in an MDT, so for me it's useful to be able to have a consultant nearby that I can talk to. I have fellow colleagues. I also have occupational health nurses and occupational health advisors, which are nurses that have more experience and are able to undertake management referrals. But also, your MDT doesn't stop there. It's you can write to a GP, you can write to a specialist, you can ask their opinion, you can ask them for more clinical information, and that can allow you to do your role, which is to give an opinion on their fitness to work. The training progression I've also highlighted already. Other things I didn't highlight are the HSC approval to become an appointed doctor. So the Health and Safety Executive is the statutory body that deals with health and safety matters, particularly with work in the UK. And there are specific kind of roles and almost like accreditation to be able to be an appointed doctor and undertake medicals, for example, with lead and asbestos or ionizing radiation. You need to have that appointed status in order to do those medicals. And there's lots of other subspecialties. HAVS is hand and arm vibration syndrome, and this is another qualification you can get to be able to do kind of more complex assessments with that condition. One of the best things about it is that there's little risk. You're only there to give an advisory role. The opinion that you give is an opinion and an opinion only. It's based on medical knowledge, obviously, and knowledge of the law. But at the same time, the onus and the law onus is put on the employers to do the certain things to protect their employees. So you often may find that you write a report, and the next time you see the employer hasn't listened to anything that you've said. At the end of the day, it's up to the employer, and the employer will be pulled in front of the tribunal judge if they're in trouble and they haven't done anything and they should have done stuff. So from your perspective, there isn't that much risk. Obviously, you still have that duty of care, so that it doesn't come without risk. If somebody has a heart attack in front of you, you can't really turn a blind eye. If somebody has a very concerning symptoms of significant weight loss or breathing difficulties, or somebody has been suicidal and admitted that to you, you can't let go of that. You still have that duty of care, so that's something that you do need to bear in mind. You advise using medical legal knowledge, and the best thing about it, as I said before, is the holistic and connectional healthcare. So you're quite a generalized medic rather than very specific in a single area or a single health concern area, like surgery or ear, nose and throat only, or dermatology only, or psychiatry only, for example. I mentioned a bit about the remote working and telephone as well as video consultations, much more prevalent in COVID, and I have a feeling that's going to change now completely for the foreseeable future with occupational medicine. I think a lot of companies and a lot of occupational health departments and companies have worked out that you can actually do the vast majority of your consultations over video, over the phone, and that's something that will likely continue, I think. Obviously, there are some safety critical medicals that you actually need to examine. For example, a train driver would need to have a vision check, would need to have a hearing check, would need to have a blood pressure check. So you would want to do that in person, for example. And I put at the end there about wearing nice clothes, watching shoes. I mean, for me, that was one of the best things that I found right at the beginning. I wasn't having to roll up my sleeves and do infection controls and tuck in my lanyard and not be able to wear a tie if I wanted to, for example. You are in a corporate setting, so you can, you can have that flexibility to wear what you want to wear if you want to. That is, I mean, I enjoy it. Other people may be quite happy in jogging clothes at home doing assessments over the telephone. So it's really up to you, really. So as doctors, obviously, we're very analytical, and I included some of the cons here just to show that I wasn't completely 100% biased towards occupational medicine. I mean, I think we obviously have to bear in mind that there are some drawbacks with whatever career choice you choose. The top one, I think, unfortunately, is quite prominent. I do have to explain to people and even my fellow colleagues that are doctors as well, that are in other fields, what I actually do, and that's something that you might find that you have to do. It's a non-treatment role, so I don't prescribe very often. You obviously can still prescribe privately because you're GMC registered, but I don't sit there and prescribe an antidepressant or an anti-hypertensive for somebody that I see. That's the role of the GP or the treating physician. So I will still advise that person to go and see their doctor, but at the same time, I won't be doing the treatment, and we have to kind of draw that very clear barrier that you don't get involved in the treatment. Your job is to find out about the treatment and give your opinion on whether the treatment is effective and whether it's likely to improve their symptoms and their function. But you're not going to be undertaking that treatment yourself. There's some stigma associated with choosing non-HS role. I mean, I think this is becoming less and less nowadays. I think more people are going out into the wider world. You see things about aesthetics, for example, and other things that doctors are now doing. So, there is some of that still, and that's something that you may want to think about, particularly if you're going towards the private sector occupational health, and that's something that you might want to consider. And the other thing I've written is not much of a follow-up for your clients or patient. I mean, it depends what kind of occupational health service you are. So if you're an in-house occupational health service, for example, a big company like Barclays Bank, you might be the occupational health within that bank and within that service. So with those, obviously, you may be seeing the same staff over and over because your job is to look after the health of the workers in that company. However, if you're a private occupational health company like Medical, for example, we have contracts with lots of different companies, and the idea would be that we provide more of a bespoke one-off opinion to try and help that company make a decision and progress through that sickness absence with that employee, or help them get back to work. But you might find that you don't actually ever really see that again, and that might be something that a lot of people might find hard to deal with at the beginning, because often you want to be able to call them back and see how they get on, or see how they are after that surgery, or see how they did after that epidural injection for their back, something like that. And you often don't get that. But then again, it depends. For example, my rail people that I look after and the workers. I mean, we have because of the contract we have with the rail company. I'll be seeing these train drivers over and over again because I want to make sure that they're absolutely fit and they remain fit to be able to drive a train. As you can imagine, you want your train driver to be fit to drive that train. Otherwise, it's risky for an accident and an injury to other people, colleagues, and members of the public. Overall, though, I think the pros far outweigh the cons, and for me, that's why I think everybody should really be considering this, at least, if not going into occupational medicine as a portfolio or a main career. So, a bit about COVID. So, as you know, COVID is something that we've been dealing with the best part of over a year now. Occupational health is very heavily involved, particularly when we talk about workplaces. We talk about the people that are clinically extremely vulnerable, and we're talking about whether they're able to return to the workplace or not, and what the Public Health England advice is for that worker and for that category, and we advise on that. So, we'd advise about social distancing, self-isolation, and how much they should be doing it. We'd also be talking to the employers. So, and I recently got given a floor plan for a control room of an energy company, and they wanted me to look at how the desks were arranged, how the one-way system worked in terms of entry into the building and exiting in the building, how the toilets worked, and really wanted to me a comprehensive overview, and they wanted me to look over it and make sure that it was in keeping with the government guidelines of how to make a workplace COVID safe and secure. So something that occupational health does get involved with. After all, we are there to advise on health and work on health and employee health. We've been advising key workers and NHS staff, and we've been helping with screening, testing, interpreting results. So particularly those people that are travelling for work, for example, and need to fly. Occupational health have been getting involved in making sure that they're COVID negative and giving them a certificate and making sure that they can, in fact, travel. Safety critical medical. So unfortunately, rail, bus, lorry, they haven't stopped. They've been carrying on. They are essentially key workers, and at the end of the day, they need to be healthy in order to do their role. So we would still be carrying on and doing those checks to make sure that they are healthy to do it. Dealing with physical inactivity and mental health or social distance. I mean, obviously there are those that are very anxious to return to the workplace because of the obvious risk within the community, but there are obviously those that actually are worse because they're at work at home and they can't go to work. There's those people that have financial troubles because furlough isn't enough to pay for their financial obligations, and those people that are diabetic and not moving around, not going being active, and their blood sugars are going up and their weight's going up. So these are the kind of things we'd also deal with. On a more general level, lobbying for PPE is something that I know that some have been heavily involved in, but occupational health have been involved in as well. Things like contact dermatitis for overwashing hands. I've mentioned financial worries and job insecurities, but also redeployment advice. If somebody is unable to return to work because of COVID risk, could you advise on another role or something else that they could do meanwhile? And essentially helps that person remain in work and carry on working rather than being on furlough or being at risk of being made redundant. A lot of what I do is public health England advice, so separate fact from fiction. So you'll hear some weird and wonderful stories of what employees or employers have interpreted the actual public health England advice. It's forever changing as well, so it's a job of mine to keep up to date and make sure that what the government has advised is being followed, and it can change week and week out. So it's something that I deal with quite a lot. And I've already mentioned about the risk assessment reviews of the workplace with the floor plan, etc. So we're coming on to the end of this presentation, and I will be able to stay on a little bit longer to be able to answer some questions and hopefully get you the answers you're looking for. But obviously, the Society of Occupational Medicine is really important that I wanted to just highlight. The oldest and largest national professional organisation within occupational health. You can see the variety of vocations that the Society of Occupational Medicine involves, and essentially, the Society of Occupational Medicine is a charitable organisation that is almost kind of like a BMA for occupational health, in the sense that they support all the occupational health practitioners. They provide us a networking opportunity and essentially just the kind of connection that you want within occupational medicine. You'll probably have heard, or you probably realize very quickly once you enter occupational medicine, that it's a very small world out there. You will come across a lot of people that are in occupational medicine, and everybody knows each other. So it's a very good thing to be getting involved with the Society of Occupational Medicine. I would strongly suggest that membership for pretty much every single occupational health practitioner should be kind of important and something I would definitely advocate. The membership's yearly. You can have different categories of membership, so if you're overseas or if you're an associate, but the main thing I wanted to highlight is for those that are students that are doing courses at, say, for example, Manchester University, there are student rates that you can inquire about, and those that are trainees, there are discounted rates as well. So my suggestion is to email the membership at som.org.uk email to find out a bit more about the pricing and how that works. And often, if you're working for a private occupational health company, for example, your company will subsidise that. Most occupational health services do, so that is something that I would inquire about. On the right, there are a few things that the SOM gets involved in and allows. Yes, you do get this big yellow occupational medicine journal 9 times a year, and it is something that has up-to-date evidence-based medicine and discussion, particularly with COVID. It's been quite an interesting thing to look at and read. Free webinars such as this, but also discounted fees to annual conferences and CBD events. So there are other events that you can get discounts if you are a member. So definitely worth looking at, and pretty much will cover your membership fee if you attend enough of them. Regional groups, particularly with GPs, as well as networking education. The appraisal service for doctors is very useful for those independent occupational health physicians that don't have a responsible body or an official appraiser. So I would definitely advocate that. Specialist interest groups, so there's a few there. The main thing there for me is CSER support. So those who are doing CSER, if you are, want to find out other people that are involved with CSER and how they're evidencing their parts of their occupational health curriculum is very useful. And certainly I found it very useful. And there is a massive WhatsApp group that is involved with CSER. So if CSER is something that you're undertaking, I would definitely recommend that you join that. But the SOM have periodical meetings with the head of CSER support group, which Dr. Claire Fernandez runs, but very useful, and it's free to attend, and I would definitely encourage that because it's useful to know what everybody else is doing. You have access to the library as well as will writing services, international financial advice, and there is a lot more that SOM do. I can't list all of that in this slide, but I would recommend that you follow that website and have a look at what membership will get you. So this is something that I thought I'd also mention, and it's particularly useful for those that are thinking about sitting a Diploma of Occupational Medicine course. So myself and Dr. Claire Fernandez have now set up a revision course. It's a supplementary course. So this is in addition to the compulsory course that the DOccMed, that the form want you to do before you apply for DOccMed. But essentially, it's much more focused towards the exam. It gives you exactly what you're looking for. We'll cover the kind of a brush over in the main concepts of occupational medicine to get you that basic knowledge in order to maximize your chances to pass. And those of you who've looked at DOccMed, you've noticed that the exam, unfortunately, is not cheap. And I know a lot of people are so keen to get into occupational medicine. Unfortunately, the DOccMed is the very basic that you need as a doctor to be able to enter. I think there are very few occupational health services companies that, and in the private sector, that will hire you if you don't have at least a DOccMed of sorts. Okay. So it's delivered by AFOM doctors, and it gives advice, is particularly with the mock viva and the portfolio, which is very kind of very different to some of the other exams that a lot of people may have done, and we will talk you through that. We will also run a mock viva one-to-one session with two of us doctors who will put you through your paces and make sure you are able to answer and articulate your answers well in a viva. We did this course in September, and we had 38 attendees who really enjoyed it and are about to sit their exam this month. And they all feel very prepared. That the feedback we've got is very positive, and this is something we're looking to continue. We're hopefully hoping to host it in March and April, so in the next few weeks to months, and that's in preparation for the May exam. And the details of that is on the Facebook group. You can also inquire with SOM, who have kindly sponsored us for this course in the past. And Medic Footprints is also somewhere else that we are putting our details on. Alternatively, please email that email there, or message us on the Facebook group and the Facebook page, and we will pick that up and be able to answer queries. So that's the end of my presentation. Hopefully you have enjoyed that, and I believe this is being recorded, so you'll be able to listen to this again for those that didn't manage to attend it live. I do have my own kind of gateway. So if you have any questions that you haven't thought of right now, or you want to kind of get in touch with me at a later date, please email the SOM at help@som.org.uk, and that will get filtered through to me, and I'll be more than happy to chat to you and keep you and answer any other questions that you might have. Okay. I'll just go through the questions that Nick has listed on the chat. I am available for another kind of half an hour or so. So if you want to hang fire or ask any more questions, feel free to. Alternatively, as I said, you can get in touch with Nick later on. So the first question. Sorry, yeah, that's my details there if you want to get in touch. But as I said, I think the best way is to go through the SOM or contact me on my LinkedIn or my Instagram there. Okay. Okay, so let's go with okay. So in terms of the first question, hi, I'm a consultant obstetrician specialising in maternal medicine. If I were to follow the occupational medicine path, will I need any additional qualifications or experience? Thanks. So again, as I said before, with occupational medicine, it's very flexible. You would need the Diploma of Occupational Medicine at the very least. This is just a basic exam. It's a generalist exam that a lot of GPs typically used to do, but obviously a lot more people are doing now. And it basically just makes sure that you understand the basic concepts of occupational medicine, that you are able to learn the basics of the legislation, so the Health and Safety at Work Act, the Equality Act, and other legislation that are required for occupational medicine. And essentially it's just the gateway. I think if you wanted to do something like Caesar and you wanted to start becoming, I don't know, lead on and become a consultant at MFOM, you should be able to apply for both the training route and the non-training route. So that would be very so that's something to think about. So second question, is there a time limit to sit in MFOM Part 2 after DOccMed? I believe that it's up to 5 years from what I imagine, but actually I'm not entirely sure there is a time limit. I think it's really up to you whether you want to sit it, when you want to sit it, and again, that's the flexibility of it. I think obviously if you're doing Caesar and you want to be able to submit all the evidence, you're going to need to have had actually sat the MFOM Part 2 and passed in order to become a consultant. You won't be able to become a consultant without that. But if you're just looking to become an AFOM after DOccMed, the MFOM Part 2 can be done at any time from what I imagine. But I think most people do it fairly quickly after, particularly if they're doing the Masters. To become AFOM by sitting MFOM Part 2 on a non-training route, is a dissertation still required? Apologies if you already said this. No, it's quite confusing, so I'm happy to repeat that. So an AFOM does not require you to do a dissertation. So an AFOM is essentially the nomials you get once you've done the DOccMed and you've done the MFOM Part 2. That's it, just those two exams. Once you've done that, you get AFOM. And as I said, most people who are already CCT'd or aren't really interested in doing lots of appraisals and portfolios and things, they don't really want to carry on and they don't want to do Caesar. AFOM is more than enough, and it's very, you're a senior occupational health physician if you're getting an AFOM, and you'll be able to apply for the majority of those roles. Okay, question 4, sorry. Does working week have inbuilt time for CPD like SPA for NHS consultants? It depends on what contract you discuss with your employer. I mean, I use that 1 hour of admin time as CPD, but actually in my contract, because I'm doing the Masters, I actually have 2 days a month that I use for the master, so it allows me to study the modules, it allows me to do my assignments and things. So that's something that I discuss with my company. I think majority of occupational health companies, particularly in the private sector, have time for CPD, and I believe that those who do the training route have a significant amount of time of study and of time. From what I was speaking to one trainee, it depends on what deanery, but they were working 5 days a week, but I think 1 or 2 of those days a week was to do with self-study and dissertation and things like that. So it was quite a lot. But that's something I guess that you need to look into, particularly if you're applying for the training route. And I would definitely talk to others that are trainees or speak to the NSOH, so the National School of Occupational Health. You are doing 7 appointments per day. Are this over phone or face-to-face? I actually do 8 appointments a day, but they're all over phone at the moment. I've been going to clinic, I think, about once a month at the moment, but even then, I mean, a lot of occupational health physicians in my company, I haven't really even been in the office since last April. So, it really depends on your expertise. The reason why I've had to go into the clinic is only because of those safety critical medicals that I mentioned with train drivers, where I can't really do a blood pressure or a vision test over the phone. But yeah, the majority are over the phone. And as I said, I haven't been into the clinic for a number of weeks now. What kind of things would you advise we can do to increase our prospects of getting employed in the private sector post CT training? Are quips beneficial shadowing post COVID? So shadowing is useful, and speak to some. Some have a connection with a variety of occupational health providers in the private world that are doing shadowing. I myself am doing something at Medigold, but unfortunately a lot of that is restricted because of COVID. We don't have clinics running and we can't have people with us, which is a shame. The other kind of things you can do is essentially just get the DOccMed and just get that CV done. Just make sure that you're able to make a corporate CV and show that you've got transferable skills. So report writing, dealing with complaints and queries, being able to meet KPIs, key performance indicators, and deadlines well. There are things, so if you look at indeed.co.uk or LinkedIn and just search occupational health physician jobs, when you see the job spec on those websites or on those links, you should be able to just work out exactly how you're going to prove that using the transferable skills you have. And this is something that I would encourage you to do after you've done the Diploma of Occupational Medicine. But I think everybody's first port of call, if you're looking to enter, you need to get the Diploma of Occupational Medicine done. That's the very basic. And then that's when employers will start looking, private and NHS occupational health departments will start looking and listening to you and looking to take you on. So Peter, I'm a GP interested in working on today with OH. What OH roles do you need DIPOccMed to do? So this is a difficult one in the sense that as a GP, you can give advice regarding health and work and health to employers if you wish to do so. It's not something that many employers often do, but I have seen occupational health reports done by a GP that doesn't have a DOccMed, and you don't necessarily need to have it, but I think it's becoming the gold standard or the very minimum now. That's the kind of platform that you need. You need the DOccMed, and I think, as a GP, if you're looking for a portfolio career 1 to 2 days a week in OH, it will be perfect for you to have the DOccMed where you can speak to recruitment companies or speak to employers around your local area and just basically say, look, I'm looking to provide occupational health, occupational health and to your company, and I want to and I'm qualified to do so. So I would definitely feel that Diploma of Occupational Medicine is at least the basic you need. I mean, everything else, AFOM, MFOM, all that's not necessary. It's just if you want to become a specialist. But in terms of the occupational health roles, management referrals, you can do health surveillance, you can do site visits, you can do risk assessment. You can do all the list that I've done. I have a Diploma of Occupational Medicine only at this stage, and I'm doing all of what I mentioned, including pensions and ill health retirement. So that you can do a lot with the Diploma of Occupational only. So also interested in 2 days a week approximately, alongside current specialty while I plan to transfer to occupational medicine full time. Okay. What kind of work is available on a part-time basis like this? A functional assessor roles have seen advertised are typically full time for a probation period. So I want to make this a little clear. The functional assessor role is not occupational medicine. It's very similar. And actually, a lot of the transferable skills that you can get from a disability assessor role, actually, you can transfer directly. And that question about the CV earlier, I think that's what made me a strong candidate to enter occupational medicine, is because I had done the diploma, I'd done the disability assessor role, and I'd got the diploma. But I would not be looking at a functional assessor if I were you. Personally, this is my personal opinion, and if you're welcome to investigate yourself. But I don't think functional assessor is a longer term role. It's great for a short term and to get those transferable skills, but I think most people move on. On a part-time basis, you can do exactly what I just mentioned with the previous role. You can literally do 2 days a week where you do management referrals and do all of the above. There are occupational health companies that take you on 1 or 2 days a week. I know in Medigold there are a few doctors that only work 2 days a week, and that's fine. They will provide you all of the software and the laptop and everything to do your role, and you just sit and do it. I mean, it's as simple as that. You don't have to work full time. And in terms of transferring over to occupational medicine full time from another specialty, perfect. Again, this is why occupational medicine is so flexible. You literally could do this. You could be doing surgery and being in theatre 3 days a week, and then do occupational medicine 2 days for the rest of the week. I mean, it really is that flexible. So I would strongly consider that. That's something that everybody should be considering if you want to just dip your toe and see what it's like. Do you need GMC number to take the DOccMed exam? Asking as overseas GP. I think you do. I mean, I'm a little unsure about the requirements, because I think it says something like the equivalent of a GMC registration, which I don't really know what it means. But if you go on the Faculty of Occupational Medicine website and look under Diploma of Occupational Medicine, my suggestion is that you look under there, and there is a requirement and specifications for the DOccMed and what you need. The other thing you can do is, if you email exams@fom.ac.uk, that is the exams portal email, and it's something that I would encourage you to follow, and they will be able to answer that specifically, and they may even ask you, can you just send your CV, and they can tell you exactly whether you're eligible or not. How does the dissertation and course content of the MSc link with the Part 2 exam for AFOM? Okay, so AFOM, obviously, AFOM is not an exam, remember, it's a nominal, but I think you mean Part 2 exam for MFOM. So the Part 2, the exit exam for occupational medicine, their Part 2 MFOM is it's so broad that in order to cover the syllabus and the requirements of what you need, the master's is very useful for that. It covers a range of stuff from policies, standards, international standards, from all the occupational hygiene stuff like noise, vibration, ionizing radiation, occupational cancers, and it also covers other stuff like statistics, epidemiology, global health, the business side of occupational medicine. So it does all of that. So that's why I recommend that you do the MSc. You don't have to, though. There are a lot of trainees that study all this in their own time, and they pass the MPhil Part 2 absolutely fine. And some deaneries for NHS in the training route actually have all of this stuff to teach you, especially in the military. I hear their training program is excellent. So a lot of them don't need to do a master's in order to sit it. But for me, if you're going to get sponsored to do it, you may as well do it, and also you get another qualification, and also you need to do the dissertation anyway for CSER and for your MPhil. So why not do the MSc? It links perfectly well, and you end up with 2 qualifications at the end. Do you need indemnity insurance, or is it provided by the employer? Most private occupational health companies will reimburse your indemnity insurance. You do need indemnity, although there is low risk in occupational medicine. You still need to be covered by it, my indemnity is based on your earnings, but your indemnity will vary depending on whether you're part-time or full-time. It's not nowhere near as much as a GP, I can tell you that, because obviously we're not treating physicians, so our risk is lower, but obviously it depends on how much you earn and what you're doing, but you do need it. So MDU, MPS, MDDUS, they all do it, so they're very common ones. Is the FOM accepting 2 years as a functional assessor, disciplinary analysis, working with Maximus and DWP as CT1, CT2 yet? Okay, so I know I've spoken to you personally before, haven't I? When I spoke to the head of CSER, and Dr. John Spiro, originally he said it was functional assessor did count, but actually they've revised that, because the functional assessor, unfortunately, there are some things that it doesn't cover, and it's not really. The idea is that they want you to be at ST, have the equivalent experience of at least up to ST3 in order to enter ST3 and enter CSER, which is essentially ST3 onwards, right? So that's why they don't want anybody that's come out of F2 and then jump straight into ST3 and then just complete the CSER in 4 years. That's not what they want. They want some experience. So my suggestion is obviously to discuss that with Dr. John Spiro and ask them. You are doing very similar reports. I understand that you are doing very similar examination, telephone assessment. And personally, for me, I think it should count, because I've done the job, and I think that functional assessment is very relevant. But I have been told that the FOM are not accepting it. What they have done, though, is they're accepting, I think, up to 3 or 4 months of the CT1, CT2 equivalent as from functional assessment. So you only would need to do kind of a year and a half in medicine or surgery or some other specialty before you can use a functional assessor to top it up to 2 years, and then go from there. I would definitely be speaking to the FOM and speak to Dr. John Spiro specifically. If you email training@fom.ac.uk. That will give you the kind of guidance. I think the form will be able to get back to you, and Dr. John Sparrow can give you his advice. You can also send your CV to Dr. John Sparrow, which is what I did, to make sure absolutely that you are eligible for CSER, and you can do that. Right, next question. If I have done ST1 and ST2 as part of GP training, but not completed the training, so I don't have CCT, does that count? And can you join as ST3? Can you join as an ST3 trainee? You can do this. This is one of the good things about occupational medicine, is it doesn't matter where the CT1 and CT2 or ST1, ST2 comes from. I think if you have done medicine, psychiatry, surgery, as long as you have done a reasonable amount of experience, they do allow you that. If you want to check specifically, especially for the training route, anything to do with training route, go to the National School of Occupational Health website. They have the specifications, and you can see whether you're eligible, and you should be able to email them. And if you email Dr. Hastrudi, Dr. Ali Hastrudi, or one of the department members of the NSOH, they will be able to tell you whether you're eligible. And again, if you just pop your CV in that email, they can see your experience and they can tell you yes or no. But one thing I will say is, if you can't get into training, you can't get in as a trainee, then my suggestion 100% is consider DOccMed and consider the non-training route. This will help you. You can get in. There's more than one way to skin a cat in occupational medicine, and I would definitely not be discouraged if you're not eligible for ST3. Also, you may also want to just complete ST3 because you just want to get CCT and get MRCGP, so that's also an option. But the number of MRCGP doctors that I have come across that don't practice GP anymore and are doing 100% occupational medicine, is a lot. Once you get to occupational medicine, I don't think many people do carry on with GP, but there are those that have the portfolio careers, and I think that's commendable. So the next question, I have a question about the portfolio aspect of DOccMed. As part of the DOccMed, the portfolio aspect requires submission of a patient interview and on-site assessment. How is this done if you aren't in occupational medicine role or job? So I would cover this on my course, and I would definitely suggest that you attend my course if you're about to sit the DOccMed. The purpose, as I understand it, the purpose of the Viva and the portfolio exam of DOccMed is not to see how good an occupational health physician is for you to portray that you understand the difference between a treating doctor and an occupational health physician. Okay, many people that submit the occupational the portfolio do so from a role that isn't involved in occupational medicine at all. So it could be a GP consultation with somebody that got, I don't know, Decurvian synovitis because they're a typist. Right? Now, you're not the occupational health physician in that role, but you may just decide that actually, you know what, you're going to see them anyway because you're treating them. But why not just ask a little bit about the hobbies, how long they've been in their job, what other things they do as part of their job. When did the symptoms start? Does it get worse with work? Is it better away from work? What kind of treatment you have? Those are the kind of things you can do, and you could literally use that case. Obviously, you would need to ask their permission and consent, so please do ask their consent. But that's it really, and you can always anonymize. You don't need to use the patient details with that. But yeah, you can do that from a GP. You can do that anyway. I know somebody who did it as who literally walked into a hairdresser, asked the receptionist, does anyone here have any problems with their skin? Because it's quite common for hairdressers to have wet work and have problems with their skin, and obviously occupational dermatitis is something that is quite prevalent, particularly in hairdressers. Literally got pointed to one of the hairdressers, took them for a coffee, decided to just chat to them for 20 minutes, take the history, look at the skin, find out all of that, and use that. That was it. And it literally could be as simple as something like that. I mean, it's difficult with COVID, unfortunately, but it really does not. You do not need to be occupational medic. You do not need that at all. The idea is that you answer the questions in the portfolio and shows the difference between whether you understand what the treating physician would do and would you be able to give an opinion on fitness to work for this person. How would you advise based on the legislation? And hopefully the headings on that portfolio and the thing will help you with that, and you can just follow the italics and put down the answers. Right, question 15. So this year on occupational medicine training, there were only 7 jobs countrywide. Is this due to COVID era, or is this actually how competitive it is in terms of entry? If so, can you give some advice what you can to boost your chances? The trainee route has a limited amount, unfortunately. This is the problem. And unfortunately, with the trainees, you have to do the interview. You have to be able to have certain specification. For example, I did 2 locum years out after my F1, F2. I could not apply for the trainee route because I have not done CT1 or CT2. I haven't done ST1, ST2. I had just done 2 years worth of experience. So for me, that's one of the drawbacks of trainee. The other thing is obviously it is competitive. Now, if you there are some people that do the DOccMed, right? And they obviously get their experience because they work as an occupational health medic. And then once they're in occupational health medicine, they then apply and then they get the training number and then they start ST3. And you can do that. However, from my perspective, and this is one of the main reasons why I gave this talk today, is that why do you if you don't get into training, and you're worried about where it is and traveling, whatever, why not go for the non-training route? It isn't that scary. It really, we really do have the variety of support and thing, and the SOM's great for that. They will literally be able to put you in touch with many people that are doing non-training routes and make you feel a little bit better, a little bit more confident, and allow you to know where you're heading with that. And a lot of people are doing the non-training route for that reason, because it's so flexible. I would personally just, if you can apply for the training route and go for it, and I would recommend it because ST3 to ST6 and the ST3 to ST6 kind of training program is very structured. The non-training route isn't structured. So for me, I would worry a little bit about the fact that you've got to be organised and you've got to have that guidance. But there are plenty of guidance out there. As I said, the SOM will point you in that right direction, and there are huge WhatsApp groups that have lots of people that will be able to help you. So I wouldn't be scared of the non-training route. So my suggestion is apply for it. If you don't get the trainee route, do the DOccMed anyway and get a job in the occupational medicine, and then decide if you want to still apply for the trainee route, or whether you actually feel, you know what, let me just do CSER, let me just do the non-training route and see how I go. And that's what I would suggest to you. To boost your chances of the entry, so look at the specification on National School of Occupational Health for the training route and look at what they're looking at in terms of specification. If you work in occupational health and you have experience in occupational health, that is going to be the best chance of you boosting your chances, because in the interview, when you do the interview and you get the scoring, you're going to do really well if you know what occupational medicine is and you know how to do it. Okay. Kate, okay, fine. So how do you do the portfolio aspect of the diploma if not currently doing occupational health? So I think I've answered that question before. So have a listen to that answer. We do run a course, and we do the Diploma Occupational Revision course. So, there are lots of guidance and tips I can do for that, but obviously I would then be overlapping with that, and which I don't want to do. But as I said, you don't have to be in occupational medicine in order to do the diploma, the portfolio part of the diploma. You'll be absolutely fine. So last question. So where can I find out where jobs count as experience for CSER? Does functional assessor and as a GP count? Sorry if you've covered this. I have covered this already. In order to find out what's required for CSER and whether you can enter, I would email the training at vom.ac.uk and ask for the specifications and send your CV in. Just literally say, this is my experience. Could I potentially undertake CSER if I get the Diploma of Occupational Medicine? And that's what I would do. Okay. All right, I think I'm running out of time there because I've got to clean it this afternoon, but hopefully that's given you guys a good run through. I'm more than willing to answer more questions, so please do send it through to the SOM and they will be able to get that through to me. There are WhatsApp groups around as well, and you probably see me pop up here and there with some words of wisdom, so please do feel free to ask there. But I think, honestly, the SOM is something that I would definitely encourage. It isn't that expensive. It can be reimbursable. There are discounts for students and trainees, so I would definitely look to sign up there and get that support and join them, because you'd be fairly isolated in occupational medicine without the SOM. All right then, take care everybody, and stay safe and healthy, and please do get in touch.